مدحت فارس. He's an adult oncologist. He's working in hospital Dammam. Was graduated from Egypt, and he was certified as an oncologist from Egypt. He got the diploma in medical oncology from Royal College of Radiology in the UK, and was qualified from European Society for Medical Oncology in 1999 and re-accredited in 2004 and 2009. He was a vice-dean cancer institution in Egypt, and he was a chairman of oncology department in the Royal city, a specialist in مثقفات. Dr. Mudhhat Fars will talk today about how to read bad news. Dr. Mudhhat, you are welcome. So you can start to talk, please, and you have 20 minutes for that.
Thank you very much, Mr. Chairman. I would like to thank the organizers for inviting me to be here in الأحساء for the first time. I would like to thank them for inviting me. Today, this is the agenda. We're going to talk about the introduction about communication skills, the importance of communication skills, how to break bad news, the communication difficulties due to system constraints, and what can be done to overcome these problems. Excellent communication between the healthcare team, the patient, and the family plays a vital role in providing better cancer care. During the health career of an oncologist is likely to conduct at least 150,000 to 200,000 consultations during his career. Unfortunately, few clinicians have received any formal training in the communication with the patient and to break bad news. It is critical to the practice of medicine, but unfortunately there is little consensus on the criteria of adequate performance of communication with our patients. I'm not going to go into details of these slides, but as you can see, to have better understanding, recall information, to reduce anxiety of the patient, to decrease the uncertainty, and to increase satisfaction, and to improve the compliance of the patient with the treatment. All this could be done through proper and adequate communication with our patient. And of course, if we communicate well with our patient, we will have better outcomes, shorter hospital stay, fewer complications and complaints, and also less meditation and resource efficient if we communicate well with our patients. First of all, what is bad news? Any news that seriously and adversely changes the patient's view of his or her own future. The gap between the patient's expectations and the reality of medical condition will define how bad the news will be. So it's very important to realize what is the patient expectation and what is the real situation. The gap between the expectation and the real situation will give you the degree how bad news it will be. You can't tell how bad any bad news is unless you have some idea of what is the patient's perception and expectation are first. So before you tell, ask. As a scheme of how to break bad news, there are 6 steps, and you can call them in one word spikes, and it's called the spikes system. S for sitting and listening, P for perception, I for invitation, K for knowledge, E for explore emotion, and S for strategy and summary. And we are going to go in depth for each point in details. For sitting and listening, first of all, what we call the clinical interview. And the basic structure of any clinical interview with any of our patients or the family is to prepare for the interview, to carrying it out and to develop trust with the patients and family, to elicit information from the patient and the relatives, to respond to patient's emotion, and then to come up with the management plan. But to have the clinical interview with the patients, with the family, first of all, you have to prepare the place where the meeting will be conducted. And the most important thing is when you have the meeting with the patient and with the relatives in an office. It is very important to notice that it shouldn't be any barriers between you and the patient. For example, you can sit in an office and in the computer and the piles of files in front of you, and you are hardly see the patient. So the communication between yourself and the patient will not be as good as we expected. If you are counseling a patient or relatives in the inpatient and the patient at the bedside, it is very important to ensure the privacy, and you have to sit down, because the eye contact with the patient and the relatives is important. So it is not advisable to communicate with your patient while you are standing and the patient is sitting, because that will give the patient the impression that you are in a hurry and you don't have time for him. So you have to sit, to be relaxed, because the patient will read our body language. So we have to sit comfortable and be relaxed. That will give the patient and the relatives the impression that we are not in a hurry and we are there for them and we are dedicated our time to discuss that with them. And of course, you should have a box of tissue just in case if the tears start to come out. So the box of tissue will be very helpful. While you are preparing for the setting, even the arrangement of the settings, we should notice that the patient, any relative who would like to attend the meeting, we should first get the permission of our patient. Anyone wants to attend that meeting, patient's permission must obtain first. But when we are arranging the meeting, the patient should sit next to the physician. It shouldn't be barriers between the patient and the physician, because that will make the patient feel close to the physician, and this is very important. Body language and eye contact is very important. Try to look relaxed, unhurried, maintain eye contact, except during the patient's distress. If the patient starts to cry, you should take your eyes away from the patient to give him space and the privacy, because everyone has his own or her own pride. So if the patient starts to cry, you should take your eyes away from the patient and to give him or her space and the private space to express his or her feelings. Listening. Listening is, there is difference. If there is anything I have said and it's not clear, please raise your hand and I can say that in Arabic. So if any sentence or any expression I'm saying is not fully understood, please just raise your hand and I will rephrase it. في فرق كبير جدا ما بين السمع والاستماع. ولو شفنا من القرآن الكريم إن لفظ السمع أو حاسة السمع دايما بتسبق باقي الحواس. يعني ربنا بيقول إن السمع والبصر والفؤاد، دايما السمع بيجي قبل الحواس الأخرى. فالسمع مهم جدا. قبل ما نبتدي نتكلم مع المريض, before discussing anything with the patient, we should listen first to the patient. And this is very important, because when we listen to the patient, we will get a lot of information. أهم حاجة المستوى التعليمي بتاع البيشنت وطريقة تفكيره. ومجرد ما احنا بنستمع ليه بنعرف احنا ازاي هنقدر نتعامل مع المريض ده وازاي هنقدر نتواصل معاه. ومجرد ما هو يبتدي يتكلم احنا بنقدر نعرف اولا مقدار المعلومات اللي عنده عن المرض بتاعه، لان ده ممكن يسهل علينا كتير جدا. ممكن جدا المريض يبقى عارف او حاسس بالموضوع، فده يأثر علينا المسافة بدل ما نبتدي من السكراتش هو بيبتدي لنا بيقول لنا هو عارف ايه. Open-ended questions, and just to be familiar with the patient at the beginning, just to ask him general questions about how is he doing and how is his condition now. Open questions, not closed question, to force the patient to answer a specific answer. While the patient is telling his story or he's telling his feelings and or expressing himself, it is very important to encourage him with simple things. Just by nodding your neck like that will facilitate the patient and to encourage the patient to tell his feeling and to express his feeling. مجرد ما تقول نعم نعم فعلا فعلا، مجرد facilitating the conversation, because most of our patients will be shy to complain or to express himself or herself. So if we wanted to encourage him, we should do that simple things. Also, repetition of what the patient is saying. For example, if the patient is saying إن الألم بتاعه غير محتمل، ممكن تقول الألم بتاعك كان غير محتمل. مجرد بتكرر نفس الكلام اللي بيقوله المريض، ده بيدي ألفة وبيحسس المريض إن أنت منتبه 100% للكلام اللي هو بيقوله، وإنك ابتديت تعيش المشكلة بتاعته. فمجرد إنك بتعيد آخر كلمة هو قالها بتدل على إن أنت مستمع له، مش مجرد إن أنت سامع بس، لا أنت مستمع ليه وفاهم، والمعلومة اللي هو عايز يقولها وصلتك. If we couldn't understand anything from what the patient said, we wanted to clarify it by simple questions. مثلا لو البيشنت قال إن هو الألم بتاعه ابتدى من فترة طويلة. فترة طويلة دي ممكن تكون أسبوع، شهر، 3 شهور، 4 شهور. To clarify، تقصد من تقريبا بالتحديد كم شهر؟ شهور ولا أيام ولا أسابيع؟ وتساعد المريض، لأنه أحيانا مجرد الانترفيو مع الفيزيشن بيبقى ده بيخلي المريض ينسى هو عايز يقول إيه. Although we should encourage the patient to express himself, we should also try to handle the time, because we know all or most of the physicians have tight schedule, so we have to play it right, to listen to our patients, and in the meantime trying to manage our time, and we should avoid to have interruption with the patients, especially the bleep and the phone calls GSM. The second point is the perception of condition and seriousness. We should express our sympathy with the patient, and we should be thorough in expressing our interest in the patient well. We should ask to know what he or she knows or suspect about the current medical problem, listen to the level of comprehension and the vocabulary used by the patient, start with the same sort of vocabulary, accept denial by the patient at this stage. If the patient is in a state of denial and he doesn't want to admit that he has or she has a serious condition, we shouldn't challenge our patient. We should allow denial and not to challenge him. Because, for example, I will give you an example. In an oncology department, if the patient is already in the oncology department وهو داخل شايف قسم الأورام، والطبيب اللي داخل عليه هو أول ما بيعرفه بنفسه بيقول له أنا من دكتور الأورام، ومع ذلك المريض بيقول لا أنا ما عنديش أورام. There is no need to challenge the patient because he knows or she knows, but she's just in a state of denial. So allow denial as a first step, then you could come again and the patient will realize the truth.
3 minutes.
The third thing is the invitation. We should invite our patient, invitation from the patient to give information. Sometimes the patient will be shy to say something about private things, and he will send messages to the physician, and he's shy to say it frankly. So in that case, the physician should read the vocabulary messages and to start to communicate with the patient regarding sensitive issues. Accept the patient's right not to know, but offer to answer questions as he or she wishes later. For example, if the patient doesn't want to know the prognosis, and he said, I don't want to know, so we should accept that. The fourth one is the knowledge. We should give them medical facts in very simple language, could be understandable by the patient and the relatives. And the strategy and summary, and this is the core thing in the management plan, because in the strategy and summary we should summarize the meeting, and it should include a plan for another interview with the patient to answer all his queries. So communication skills, because communication skills are not a substitute for the correct management, they are an essential to the management plan, not a substitute for making the right decision. Just trying to save time. There are some difficulties in communication. Consultation takes place in environment, again, this is a practical of good skill. For example, if there is no proper place for consulting, less privacy, constant interruption, this is not good for the communication with the patient. Some clinics are much pressurized and there is no time to conduct that with the patient. Lack of communication between different specialties, because communication is not only between patient and physician, it should be between physicians, between among the different specialties, and between all the healthcare providers. And thank you very much.
Thank you, Dr. and for your time. Thank you so much. Now the tool for